Welcome to This Explainer. Today, we're jumping straight into demystifying the completely overwhelming cascade of critical illness. We're going to trace exactly how a localized infection triggers systemic, multi-organ shock. We'll be breaking down the root causes, the pathophysiology, the clinical signs, and the exact investigation and management protocols you absolutely need to know. So, here is our roadmap for today. We'll be hitting 1. The anatomy of shock, 2. The cellular battlefield, 3. Coagulopathy and microthrombi, 4. Organ failure and hypoperfusion, 5. Triage and resuscitation, and finally, 6. Breaking the vicious cycle. Let's get into it. Starting with Section 1, the anatomy of shock, defining the crisis. We often think of shock simply as just having low blood pressure, right? But the absolute crucial takeaway here is that it's fundamentally a widespread failure of oxygen delivery to your cells. The causes? Well, they can vary. It could be distributive, like when blood vessels dangerously dilate, cardiogenic, when the heart fails as a pump, hypovolemic, from massive fluid or blood loss, or even obstructive. But honestly, no matter the cause, the end result is exactly the same: cellular starvation. Similarly, sepsis isn't just a really bad infection. It's actually a scenario where the host's own immune response goes completely off the rails. So instead of just fighting the invading bug, the immune system turns its devastating arsenal on the body's own tissues. It's essentially friendly fire, leading to life-threatening organ dysfunction. Moving right along to Section 2, the cellular battlefield and endothelial activation. Let's look at how this builds at the microscopic level, right at the inner lining of your blood vessels. The pathophysiology here is sequential. It behaves like a microscopic domino effect. Step 1, your body recognizes pathogen signals, which are known as PAMPs and DAMPs. Step 2, this triggers a massive activation of the endothelium, which are the cells lining your blood vessels. Step 3, this activation strips away the protective coating of the vessels, called the glycocalyx. And finally, Step 4, the tight junctions holding these cells together are totally destroyed. This creates a leaky barrier, causing your capillaries to literally dump vital fluid straight into the surrounding tissues, which leads to systemic edema and plunging blood pressure. This quote brilliantly illustrates our core concept. The true battleground of shock isn't just the heart or the lungs. It is the compromised wall of the vascular system itself. When that barrier fails, the entire system crashes. Section 3. Coagulopathy and microthrombi, the clotting cascade. As these blood vessels leak and break down, they kind of become this deadly, sticky trap for circulating cells. Let's build a quick mental cheat sheet for sepsis-induced coagulopathy and DIC. First up, the causes and pathophysiology. Endothelial injury triggers a massive prothrombotic response. Tissue factor expression skyrockets, which kicks off the clotting cascade. The damaged endothelium releases von Willebrand factor, grabbing onto platelets. Meanwhile, activated neutrophils actually cast these web-like immune structures called nets that trap cells and debris. And to make matters worse, elevated PAI-1 completely impairs your body's normal ability to break down these clots. So you end up with microscopic clots everywhere, physically blocking oxygen from getting to your tissues. Now, get this. Here's a really surprising fact. This unchecked clotting uses up the body's coagulation factors so rapidly that 35% of septic shock patients develop disseminated intravascular coagulation, or DIC. And this leads directly to our clinical signs. Because the platelets and clotting factors are all used up, creating these microthrombi, the patient paradoxically starts experiencing severe, life-threatening bleeding from other sites. On to Section 4, organ failure and hypoperfusion, taking the macro view. Zooming out from the cellular level, let's explore how these microthrombi and leaky vessels actually manifest at the patient's bedside. You might see two very different presentations. Distributive septic shock presents with profound vasodilation, meaning the patient might actually feel warm initially due to systemic inflammation and leaky capillaries. Cardiogenic shock, on the other hand, presents with a failing pump and low cardiac output, usually leaving the patient cold and clammy. But here is the thing. Both ultimately lead to the exact same catastrophic endpoint, which is severe cellular starvation. So what does this look like? Here are the specific clinical signs of this cellular hypoxia cascading into macro-organ failure, and the reasoning behind them. The kidneys suffer acute tubular necrosis from the hyperperfusion, which presents as drastically reduced urine output, oliguria, and elevated creatinine. The liver becomes ischemic, which bumps up bilirubin in half of all patients. The brain, being starved of oxygen and basically bathed in inflammatory cytokines, presents as altered mental status or lethargy. And the lungs, suffering from those leaky pulmonary capillaries we talked about, develop ARDS, acute respiratory distress syndrome, making oxygenation nearly impossible. Section 5, Triage and Resuscitation, diving into the ICU protocols. Knowing the immense biological damage that's occurring, how do we systematically investigate and manage this? Well, looking at our investigation protocols, what is done first? You prioritize serum lactate. That is your direct gauge of hypoperfusion severity. You absolutely must draw blood and urine cultures before giving antibiotics to identify the specific pathogen. You'll also need a CBC to check for an immune left shift. And to catch that DIC we just discussed, you need a full coagulation panel, PT/INR, D-dimer, and fibrinogen, to see exactly where their clotting factors stand. Once those investigations are cooking, the management protocol steps in immediately. Step 1, secure massive access with 2 large-bore IVs or a central line. Step 2, aggressive fluid resuscitation. We want to rapidly restore volume with roughly 30 milliliters per kilogram of balanced crystalloids. But, and this is a big but, you have to be cautious. Remember those leaky pulmonary capillaries? Too much fluid too fast can actually worsen their respiratory failure. In step 3, hit them hard and fast with broad-spectrum antibiotics. Now, when fluids leak out or just aren't enough to maintain a mean arterial pressure of 65, we systematically bring in specific vasopressors. Norepinephrine is your absolute first-line agent to clamp down on those dilated vessels. If that's not cutting it, we add vasopressin as a second line, followed by epinephrine. And if an echocardiogram shows the heart is failing as a pump, we add dobutamine to increase contractility. And let's look at the management protocol for the hematologic disaster of DIC. Because this bleeding can be fatal, providers use exact thresholds to replace the consumed clotting factors. If fibrinogen drops below 150, we give cryoprecipitate. If platelets crash to 50 or below and they are actively bleeding, we transfuse platelets. If the PT/INR is prolonged with active bleeding, we go with fresh frozen plasma, and we top up packed red blood cells if their hemoglobin drops below 7.0. It is a highly calculated balancing act. And finally, Section 6, breaking the vicious cycle. Ultimately, survival in the ICU depends completely on our ability to interrupt this self-amplifying cascade. This feedback loop right here is what makes shock so deadly. Hypoperfusion leads directly to lactic acidosis, and that resulting acidic environment literally blunts the effectiveness of our life-saving vasopressors, the catecholamines. Because the drugs stop working as well, the hypoperfusion worsens, creating this fatal downward spiral. To break this cycle, we deploy adjunctive therapies. We give IV hydrocortisone to patients with ongoing vasopressor needs to combat adrenal insufficiency and help stabilize vascular tone. We use mechanical ventilation with low tidal volumes to protect those ARDS damaged lungs while forcing oxygen into the blood. But above all else, we need early source control, whether that's draining an abscess or removing an infected central line. Without eliminating the root source, the inflammatory cycle will inevitably continue. I want to leave you with a final thought today, challenging us to look a bit beyond the traditional mechanics of the ICU. If everything we've explored today proves that shock is fundamentally a disease of microscopic vascular failure, are our macro-level fluids and pressors really just buying time until the body manages to repair its own glycocalyx? It's a pretty fascinating perspective on where targeted, microscopic critical care might be heading in the future. Thanks for joining me on this explainer, and keep questioning the science behind the symptoms.